He is also assistant professor, Vivekananda Institute of Postgraduate Medical Sciences. He is now the vice president of Indian Society of Gastroenterology, West Bengal chapter. And now I will request Sudipto to please introduce our main speaker and please start today's class.
Thank you very much, Dr. Sharkar, and thank you to the organization for giving me a chance to use this podium. It is my proud privilege to introduce Professor Sudhir Mehta to this August gathering. He is a Pro-Chancellor of NIMS University. He is a Director and Senior Professor, Department of Medicine, NIMS Jaipur. He was a former Senior Professor and Head of the Department of Medicine, SMS College of Jaipur. He has got lot of many activities. He was a member of National Task Force of VTE and ICMR. He's a member of Finance Committee of National Academy of Medical Science. He's a member board of PRF, and he's one of the main investigator of Rapid Round trial. He was an editor on monograph on platelet disorders and common hematological diseases. He was also in the advisory board. He is the chairman ethics committee of Amity University Jaipur, and he had over 130 national and international publications, and he delivered over 100 guest lectures. We would like to hear from him. Professor Mehta, please.
Any problem, Dr. Mehta? Hello? Yes. Dr. Mehta, any problem?
Offline হয়ে গেছেন নাকি?
উনি সেটা সাসপেক্ট করেছিলেন, সেই জন্য আমাকে বললেন আমি কল করছি ওনাকে। ঠিক আছে,
কল করো তো, এতক্ষণ তো ছিলেন
না, এখন ছিলেন তো।
স্যার উনি আছেন এখনো? Dr. Mehta, please start your deliberation. We cannot hear you. We cannot hear you.
No, you can hear me?
Yes,
Yeah,
sir,
yeah.
now we can hear.
I do not have the full screen.
Yes, sir, it is already full screen, sir.
But it's not, at my end, it's not the full screen.
No, it's from our end, it is okay. You start. Please start.
Okay.
You have already been introduced by our chairperson. Please start.
Yeah. Nick, can I have the full screen from your end? Because it's not coming on my laptop.
Sir, I have already shared your slides. As
Yes.
you will go on speaking, sir, I will change the slide.
Yeah, okay, so okay, it's not full screen. Still, I am having those, the slides are smaller at my end.
Rupak, we are also seeing little bit.
Hey, Rupak, you do one thing. তুমি তাহলে ইয়ে করো না,
Can you
স্যারকেই করতে দাও।
Can you enlarge the slides?
রূপক, তোমার ফোনটা একটু ঘুরিয়ে নাও, রোটেশনে অন করে দাও, এটা বড় হয়ে যাবে। হ্যাঁ, ঠিক আছে।
Yes, yes.
Okay, fine. Yeah. Thank you, Dr. Ghosh, for your kind words. And thanks, Dr. Sarkar, Dr. Karmatar, and your team for giving me this opportunity to interact with all of you. I have particularly chosen this topic for many reasons. And some of these reasons is the celiac disease is amongst one of the few diseases which usually present in atypical fashion, especially in adults. And therefore it is confused with large number of GI diseases like giardiasis or H. pylori infection, irritable bowel syndrome, and so on. Now, although the celiac disease is considered as a benign disease, still it carries a small but absolute increase in overall mortality, especially when it is associated with enteropathy-related lymphomas. The third important reason is that hypersplenism is commonly seen in nearly 30 to 60% of adult patients with celiac disease, but it is largely ignored in day-to-day clinical practice. And the most important reason why I have chosen celiac disease as today's topic is that this entity is difficult to diagnose in areas where rice is the staple diet. And most of the attendees in today's lectures are from Bengal and Northeast, where rice is the staple diet. Now, because of the low gluten exposure, so patients who do have are at risk for celiac disease either have mild or they have no symptoms. All the more, they usually present with atypical symptoms like anemia, osteoporosis, or infertility, rather than the GI symptoms. Now, because of low exposure to gluten, the diagnostic tests, they gave me false negative serology, and even the intestinal biopsy always look like near normal. This is because of very exposure to very minute amounts of gluten in the diet. And now because of this, there's a lower index of suspicion among the clinicians, and that's why it leads to underreporting. And that's why if you go to the literature, the prevalence of celiac disease is reportedly low in areas in populations where those consume rice as the staple diet. And moreover, in these areas where rice is the staple diet, especially in Bengal and Northeast area and some part of the South India, the symptoms and signs of celiac disease, they overlap with the nutritional and infectious disease. Yeah, previous slide, please. Yeah, previous slide.
Okay.
Okay. Now, celiac disease is also known as gluten sensitive enteropathy, is a common immune-mediated inflammatory disease of the small intestine, which is result of sensitivity to the dietary gluten and the related proteins in persons who are genetically predisposed. Next slide, please. Now, why I have included celiac disease because a very high index of clinical suspicion is essential to diagnose celiac disease. Because very often it presents with subtle, atypical, or extra-intestinal symptoms, which can be overlooked or can be misattributed to other disorders. At times, because of delayed or misdiagnosis, there is significant morbidity. There's increased risk of autoimmune diseases and even malignancies, especially the lymphomas. Now, a number of observational studies have clearly shown that patients who have celiac disease have a small but absolute increase in the overall mortality as compared with the general population. Next slide, please. Now, coming to the pathogenesis of celiac disease, they are mainly the genetic predisposition along with the environmental insult and exposure to the gluten and related proteins in the diet. Now, the genetic basis of celiac disease is supported by two observations, that there is a frequent intrafamilial occurrence, and there is a remarkably close association with the HLA antigens DQ2 and DQ8 gene locus. In fact, almost 100% of patients with celiac disease who have positive serology and have confirmed on histology have HLA DQ and D8 as compared to the general population where this HLA genotype is found only in 30 to 40% of the populations. Those individuals who are homozygous for the HLA DQ are at increased risk for celiac disease as well as for the enteropathy associated T-cell lymphoma. Next slide, please. The contribution of HLA genotypes into the development of celiac disease among the siblings is only 36%. That means there are some other genes or the non-HLA genes are also responsible for expression in the siblings. Now, these non-HLA genes have been identified and they influence the susceptibility to the disease, but they contribute only to 3 to 4% to the genetic risk as compared to the HLO genotypes, which contribute around 30 to 40% for the development of celiac disease. Next slide. Now, the second important pathogenic mechanism is the mucosal immune response. Now, the immune responses to the gliadin and the related proteins, they promote an inflammatory reaction. There is infiltration of the lamina propria and epithelium with chronic inflammatory cells, and there's the atrophy of the villus. Now, this immune response at the mucosal level is mediated by both the innate as well as the adaptive immune systems. Of course, the detailed pathogenesis, of course, would be beyond the scope of this lecture. Next slide. Yeah, okay. And now the prevalence, coming to the prevalence of celiac disease, is estimated globally around 1%. But if you use the serologic along with the biopsy verification, the reported prevalence is 1:70 to 1:300 in most of the countries. And this global distribution of disease parallels the distribution of HLO genotypes, which predispose to CD, that is the DQ2 and DQ8. Now, just various population-based studies have shown that, like in so many other diseases, the confirmed cases of CD just represent the tip of the celiac iceberg. There's a huge burden of under-diagnosed, under-recognized celiac disease in the population, especially in areas where wheat is not the staple diet. Now, who are the individuals who have low probability of developing celiac disease? Those who do not have signs and symptoms of malabsorption like diarrhea, steatorrhea, or weight loss. There is no family history, or they have descent belonging to Chinese or Japan or sub-Saharan Africans. However, those individuals who are suspected, though are at low risk, but are suspected to have celiac disease, should undergo only serologic testing. That is, the most common is the TTGA IgA. However, those patients who turned out to be positive in serology should undergo the upper endoscopy along with the small bowel biopsy to confirm the diagnosis. Next slide, please. Now, there are certain individuals who have high probability of developing celiac disease, and these are those who present with features of celiac disease like chronic diarrhea, steatorrhea, weight loss, or failure to gain weight. And these individuals, those who have risk factors, which I will enumerate in my next slide, for which are at higher risk of developing celiac disease, and they have persistent GI or extra-intestinal symptoms and signs. These are the individuals who are at high risk, and they should be subjected to both serologic testing as well as small bowel biopsy, even though the serologic biopsy may not be positive. It's very important that all individuals who have a high probability of celiac disease should undergo not only serologic testing, but also small bowel biopsy. Next slide, please. Now, who are the individuals who they constitute a high-risk groups? These are the first and second degree relatives of patients who have confirmed celiac disease. And it has been shown in a meta-analysis that the prevalence of celiac disease was nearly 9% for siblings, 8% for offsprings, and 3% for the parents of celiac disease. Now, other individuals who are at increased risk for celiac disease include those who have type 1 diabetes, autoimmune thyroiditis, who have Down or Turner syndromes, or pulmonary hemosiderosis. Next slide, please. Now, before taking up the case scenarios of the celiac disease, there are various nomenclatures are there to describe the various phenotypic expression of celiac disease. The classic celiac disease is one where the standard criteria for diagnosis is present, that is, serology is positive, the small duodenal biopsy is positive, suggestive of celiac disease, and the patient has signs of malabsorption like diarrhea, steatorrhea, weight loss, or growth failure. And this type of classical celiac disease is usually seen in childhood. Usually, it is less commonly seen in adults. The non-classic variety of celiac disease is those individuals who meet the standard criteria for celiac disease, but they do not have the signs and symptoms of malabsorption. Now, this is more common in older children and adults. Subclinical celiac disease describe those who already meet the standard criteria for celiac disease, but they have symptoms which are below the threshold of clinical detection, and they would not otherwise trigger the testing in routine practice. And in the past, this terminology, that is the subclinical, was used as silent celiac disease. Now, symptomatic celiac disease is one where the patient has all the symptoms consistent with the GI or the extra-intestinal symptoms of celiac disease. Asymptomatic are those which are actually, they meet the criteria for diagnosis of celiac disease but do not have symptoms. And a very important nomenclature to describe celiac disease is the potential celiac disease. These are the individuals who have positive serology but have normal intestinal biopsy. Now, these are usually identified on the basis of screening or because of some other investigations. And many of these patients, they revert to negative serology or can have persistent serology without the manifestation of symptoms of celiac disease. Next slide, please. Now, coming to the various case scenarios, which will describe what are the way that celiac disease is basically a multifaceted disorder. And some of these case reports will clearly see that how we can pick up these cases in a day-to-day clinical practice. The case one describes a patient of 35-year-old North Indian Hindu male. And now he came with a complaint of gradually progressive fatigue since 3 months. On examination, except for pallor, there was no other remarkable feature. Patient was subjected to investigation. The most common, of course, for anemia was CBC. Patient had moderate hemoglobin, 8.2. MCV was almost near normal toward the lower end. RDW CV was raised. RDW SD 65. I cannot see the lower part of the slide. Can you just decrease the size of the slide? Yeah. Okay. No, decrease the size. Yeah. And the red hemoglobin equivalent was 26 picogram. Now, from this, you can see that this patient has almost normocytic anemia. Okay. No, it's fine. It's fine. Just a little more decrease in the, yeah. This patient had almost normocytic anemia with both CV and SD RDW were raised. And of course, the retic hemoglobin equivalent is less. Now, this shows that probably this patient has dimorphic anemia and therefore peripheral smear was ordered. Next slide. Now, this is a representation of the RBC histogram, which was there in the printout of this patient. Now, if you can see the one which is the histogram RBC, which is filled with RBC, is a normal histogram. There is the expansion of this histogram both towards the right as well as towards the left. That is, there is the presence of macrocytes as well as microcytes. So, looking at this histogram, one can make a diagnosis. Yes, it is a case of dimorphic anemia. And of course, it is confirmed by the high value of RDW-CV as well as RDW-SB. And if you look at the peripheral smear, you can find the microcytes and the macrocytes. So this was a case of dimorphic anemia. Next slide, please. No. So next slide, please. So this patient was further investigated. Iron studies were done. T-set transferrin saturation was low. Ferritin was low. Stool was examined for apple bud. There was nothing abnormal. Serum folate was normal and B12 was low. Next slide, please. So this was diagnosed as a case of dimorphic anemia, was treated at the OPD level, and patient was given a single tablet of albendazole and was prescribed oral ferrous ascorbate and B12 and folic acid. And of course, the patient was asked to come up after 2 months. And when the patient revisited OPD, there was no improvement in the clinical symptoms and the hemoglobin almost remained the same. Next slide, please. This patient was further investigated by the internist. HPLC was done to rule out beta-thalassemia, which turned out to be normal. Endoscopy was done to find out is there any occult blood loss from the upper GI, but what it showed was the scalloping of the duodenal mucosa. And when the biopsy was taken, it turned out to be there was marked villus atrophy. And then serology was done, which was strongly positive. And finally, the diagnosis was refractory dimorphic anemia secondary to celiac disease. Next slide, please. Now, coming to the discussion points on this case. Now, anemia is one of the commonest hematological manifestation of celiac disease. It may be a presenting feature in nearly 12 to 69% of patients, and the higher prevalence is seen in adult or older children. Now, this celiac disease should always be kept as a differential diagnosis in the workup of refractory anemia. And nearly 20% of patients with refractory anemia usually, especially the pediatric patient population, have celiac disease. Now, this occurs because of malabsorption of iron, B12, and folic acid. And there are other nutrients which can contribute to anemia, which include the malabsorption of copper, vitamin B6, pantothenic acid, and riboflavin. Because of the malabsorption and paucity of these hematopoietic growth factors, there is hyperproliferative anemia. And now it is always a dictum that even if a patient undergoes endoscopy and the endoscopic appearance of the duodenal mucosa is not suggestive, but if serology is positive and you have a patient who does not respond to treatment of anemia, then the biopsy should be done. And it is very important that the biopsy should be taken from at least 2 biopsies from the duodenal bulb and at least 2 to 4 biopsies from the distal part of the duodenum. And these biopsies should be properly labeled because the mucosal architecture of the duodenum is different from the distal part of the duodenum. So many times what happens that even in a normal person, the biopsy from the duodenal bulb can show villus atrophy, mild degree of elliptrophy, and the patient can be erroneously diagnosed as a case of celiac disease. Now, I've already discussed iron deficiency, which is usually refractory, can be sole presentation, and this is because of malabsorption. Now, the folic acid deficiency usually present as megaloblastic anemia, but only there is either mild thrombocytopenia or mild leukopenia can occur usually in patients who have folic acid deficiency. Now, since serum folate is dependent on your dietary intake, and is frequently increased if there's a concomitant B12 deficiency. And therefore, one always go for red cell folate. Though red folate is not very specific for folate deficiency, especially in presence of concomitant B12 deficiency. But it is less subject to the variation because of the dietary intake. So the test which is very important to diagnose folate deficiency is the homocysteine level, and it can diagnose folate deficiency because it is less affected by the deficiency or concomitant deficiency of B10 or dietary intake. Next slide, please. Now, what are the causes of B12 deficiency? Besides the malabsorption, there could be the decreased gastric acid, bacterial overgrowth, there could be presence of autoimmune gastritis, or there could be a dysfunction of the small intestines. And it has been seen that untreated patients with celiac disease, especially adults, nearly 8 to 41% have deficiency of B12. Now, copper deficiency has also been described and can result in anemia and thrombocytopenia. Next slide, please. So basically, the hematologic manifestations of celiac disease should be kept in mind, especially a deficiency of iron, B12, and folic acid, and of course, deficiencies of even copper, which can cause anemia along with thrombocytopenia. Now, coming to the second case, a 45-year-old female, she came with recurrent diarrhea and weight loss in 3 months. The diarrhea was large volume, greasy, and difficult to flush. On examination, she had pallor, she had pedal edema, and she had multiple ecchymosis over both forearms. When she was integrated further, she gave a history of easy bruising over the limbs over 2 months, though there was no history of intake of anticoagulants, antiplatelets, or non-steroidal anti-inflammatory drugs. When she was subjected to investigations, her hemoglobin was 8.6. Platelets there was mild thrombocytopenia, MCV was normal. Peripheral smear showed anisocytosis with presence of both microcytes and macrocytes. Albumin total protein was less. Albumin was 2.4, which accounted for pedal edema. LFTs and the pancreatic tests were normal. Patient was negative for HIV 1 and 2. Next slide, please. Next slide. Next slide, please. Yeah, iron studies was done, ferritin turned out to be low. Stool examination was unremarkable. Again, B12 came out low. Vitamin D and calcium turned out to be normal. Bleeding time was normal. Next slide. Now, because of icomocy, coagulation test was ordered. It came that the PT was prolonged, APTT was prolonged. So both the coagulation, the intrinsic and extrinsic parameters were prolonged. And therefore, to rule out other disease, the patient underwent further coagulation test, but FDPD, dimer, fibrinogen, and von Willebrand all turned out to be normal. Now, because of this bleeding diathesis and anemia that is dimorphic, patient was subjected to endoscopy, which showed scalloping of the duodenal mucosa, and the biopsy which was taken showed marked venous atrophy with trip hyperplasia, and serology, ETG, IgA was done, which was markedly positive. So this was a patient of celiac disease with dimorphic anemia and coagulopathy. And how do you manage this coagulopathy? This is the coagulopathy is because of deficiency of the vitamin K, and you manage with gluten-free diet, parenteral vitamin K, and treat the dimorphic anemia with parenteral B12, and the iron that is the most commonly parenteral iron which we use is the ferric carboxymaltose. And this once the stores are corrected, the patient can be followed with the oral supplements. Next slide, please. Now, this coagulopathy, which is seen in patients of celiac disease, usually secondary to vitamin K malabsorption. And because of vitamin malabsorption, there's a deficiency of coagulation factors 2, 5, 7, 10. And hence, both the intrinsic and extrinsic pathways are affected, and therefore, prothrombin time and partial thromboplastin time are raised. And usually, these patients present with skin or subcutaneous or muscular bleeding. And even these patients can have unexplained prothrombin, like prolonged prothrombin time, even in the absence of clinical bleeding. I've told you the treatment is you treat with parenteral vitamin K along with the gluten-free diet. Next slide, please. Coming to the case number 3, a 52-year-old male smoker. He came with complaints of abdominal discomfort, weightless, increased fatiguity since 1 month. On examination, there was only pallor was there. CBC and peripheral smear revealed microcytic anemia. Ultrasound was normal. Stool occult blood was positive. Next slide. And because of occult blood positive, patient was subjected to endoscopy, colonoscopy, thinking that there could be a malignancy which turned out to normal. And subsequently, an upper endoscopy was done. But what happened that when it was endoscopically, there was a suggestion of celiac disease in terms of the scalloping of the duodenal mucosa and presence of the ulcer in the D2 part of the duodenum. A biopsy was taken and which revealed on immunohistochemistry T cell lymphoma. And then this thinking because of T cell lymphoma, suspicion of celiac disease was made, and serology was turned out to be positive. Next slide. So in patients of celiac disease, lymphomas can complicate it, untreated long-standing patients, and usually it is the T cell lymphoma, but both B cell as well as extraintestinal lymphoma can be seen. There is a clonal proliferation of intraepithelial lymphocytes, and the relative risk of especially the T cell lymphoma in celiac disease ranges from 2.1 to 6.6. And these are the CD3, 7, and 103, which are positive in these patients. And these patients are usually treated as for the lymphomas. However, the treatment for T cell lymphoma is less surprisingly, and despite even a lot of protocols, the prognosis is not so good as far as the T cell intestinal lymphomas is concerned. But B cell lymphomas or the external intestinal lymphomas are treated like all other lymphomas. Next slide, please. Next slide, please. Next slide, please. So to summarize that among the three cases which have taken, what are the hematologic manifestations of celiac disease? Anemia, what we have seen is common. Thrombocytosis is common and is commonly seen, especially in secondary to iron deficiency, or could be hypersplenism. Of course, I'll take one case of hypersplenism. Thrombocytosis, because it is an inflammatory disorder, and therefore thrombocytosis can be seen in as a part of the inflammation in celiac disease. Thromboembolism is uncommon, of course, but it is a rare manifestation of hyposplenism. Leukopenia and neutropenia are again uncommon. What I've already said, hyposplenism is seen in good majority of patients, especially adult celiac disease. And of course, it is less commonly associated with infections as compared to hyposplenism because of some other cause. Next slide, please. So coming to case number 4, a 40-year-old female, she came with persistent fatigue, weight gain, despite she was taking levothyroxine. And she was diagnosed as a case of hypothyroidism 3 years back. And over the 3 years period, it has been seen that her TSS levels was always high. And recently she had increased the dose, but there was no clinical improvement. And at the same time, she complained of intermittent loose stools. Next slide, please. So on examination, she was pale looking. She had mild periorbital puffiness. Thyroid was mildly enlarged with soft texture. She had a normal BMI. On investigation, anti-TPO was positive. TSH was raised, though the patient was taking almost 125 microgram of thyroxine. All of the tests, including the blood biochemistries, were within the normal limits. Next slide, please. Because suspecting that this could be because of she was a case of autoimmune hypothyroidism, and of course, and celiac disease is one condition which can cause autoimmune hypothyroidism. Is usually associated. So the serology was done, and IgA was strongly positive, and subsequently a renal biopsy was done, and which showed MASH 3 villus atrophy, and the final diagnosis of this patient was celiac disease with autoimmune hypothyroidism. Now, I've already told you in the previous slide that celiac disease is associated with large number of autoimmune disease, and the most common is the type 1 diabetes and the autoimmune thyroid disease. Among these, more autoimmune hypothyroidism is more frequent than hyperthyroidism, and this occurs, and this uncontrolled hypothyroidism, that is the elevated level of TSH, is because of the malabsorption of the hormone in untreated celiac patients. And therefore, there's a clinical dictum is there that all autoimmune hypothyroid patients, especially who have poor control, should be screened for celiac disease. And the management, the most important is to gluten-free diet throughout life, monitor the thyroid function, and of course, with gluten-free diet, the absorption of thyroxine improves and patient becomes euthyroid. Now coming to case number 5, a young male who presented with chronic itchy vascular rash on elbows, knees, and buttocks. And he was having this rash intermittently for 2 years. There was no significant GI complaints. On examination, the systemic examination was normal, but on examination of the skin lesions, there were symmetrical grouped vesicles with papules, with excoriations was there. This patient had normal BMI. Next slide, please. These were the papules and the vesicles present on the knee joint. Next slide, please. These are the inflamed papules which are present at the elbow. So therefore, this patient was referred to the skin specialist. We performed a skin biopsy from the lesion which showed the subepidermal vesicles with neutrophil accumulation, and immunofluorescence of the non-lesion skin showed the presence of IgA at the double papillae. So therefore, suspecting the celiac disease, the patient was referred back to the internist to evaluate for celiac disease. So the serology turned out to be positive. The biopsy was suggestive of celiac disease, and therefore patient was finally diagnosed as a case of dermatitis herpetiformis with associated celiac disease. Next slide, please. Now, the dermatitis herpetiformis is a very specific cutaneous manifestation of celiac disease. So, if you have a patient who have skin findings, these skin findings may precede all other symptoms of celiac disease, especially the GI symptoms, by years and decades. And if you have a diagnosed patient who is diagnosed histopathologic, then by DH, there is no need to perform the duodenal biopsy. Even the positive serology is good enough to label as a case of confirmed celiac disease with dermatitis herpetiformis. The treatment, of course, the most important treatment is the gluten-free diet throughout the life, and you treat the dermatitis with Dapsone. Next slide, please. Now coming to case number 6, a 45-year-old male. He came with complaint of low back since 3 years. He had no neurological symptoms, no fractures, no abuse of steroids. Occasionally complained of bloating and fatigue, which was not very vague and which could not be related to the main presenting complaint. Patient had normal BMI, and there was on examination of the spine, there was no abnormality. The neurologic examination was normal. Next slide, please. The patient was investigated. The MRI turned out to be unremarkable. DEXA was performed and patient had osteoporosis of the lumbar spine. Patient had mild hemoglobin anemia. Calcium and phosphate was mildly low. Vitamin D was low. PTH was high, suggestive of secondary hyperparathyroidism. Patient was referred to the endocrinologist who had advised calcium, vitamin D, and the bisphosphonates weekly. Then to find out the cause, because there was the endocrinologist again had referred back to the internist to see that is there any probability of any metabolic disease. The patient was subjected as per the protocol for celiac disease, and the TTG turned out to be positive, and it was confirmed on biopsy. And finally, this patient was diagnosed as celiac disease with secondary osteoporosis. And like all other patients of celiac disease, the most important sheet anchor of therapy is the gluten-free diet, along with supplementation of calcium, vitamin D, and bisphosphonates. Now, looking at this case number 6, now bone disease, metabolic bone disease could be the only presentation of celiac disease, especially in adults. And this is because of the malabsorption. And therefore, any celiac patients more than 30 years of age who complains of vague bony pains should always be screened for celiac disease. Next slide, please. Coming to the case number 7, a female 46-year-old school teacher. She came with complaints of recurrent upper respiratory tract infections over the period of 12 months. She had persistent fatigue. Of course, she did not complain of any loose motions. There were no weight loss. Next slide. She had a history of iron deficiency anemia 2 years back, and she had received oral iron intermittently. She was recently hospitalized for pneumococcal pneumonia and was hospitalized and treated. And there was no, in the past, there was no history of autoimmune disorder. There was no family of any GI disorders. Patient was not vaccinated in adulthood. Next slide. On examination, she had mild pallor. Systemic examination did not reveal any important clinical finding. Patient had anemia, which was microcytic. Red hemoglobin equivalent was low. Ferritin was low. Peripheral smear was done, which revealed this. This is what you will see is the pigmentation within this. This is the Howell-Jolly bodies, and then you can see these are the target cells. So besides the presence of the microcytes and the payload, you had the target cells and the Howell-Jolly bodies. And the Howell-Jolly bodies are characteristically seen in patients who either have splenectomy or have functional hyposplenism. No, there was no history of splenectomy in this patient. Next slide, please. This patient was further investigated, including the IgA was done, TTG was done, spleen size was turned out to normal, and for functional hyposplenism, patient underwent the technetium-99 sulfur colloid scan, which showed reduced splenic uptake, and then the biopsy endoscopy was done. Biopsy was suggestive of villus atrophy. Next slide. So the final diagnosis in this patient was celiac disease with secondary hyposplenism and iron deficiency anemia. Next slide. This patient again was managed with gluten-free diet. She was advised vaccinations with pneumococci, meningococcal, and Haemophilus influenzae. And she was, because of recurrent infection, she was given prophylactic antibiotics. And because of anemia, low ferritin level, she was infused with ferric carboxy maltose. Now, what I've already said in pertaining to case number 7, hypersplenism is seen nearly in 30 to 60% of adult patients with celiac disease, and it is more common when celiac disease is associated with other autoimmune disorder like type 1 diabetes, autoimmune thyroid disease, or when the celiac disease is complicated by lymphoma or ulcerative gingivititis. Now, we do not know what are the risks which are associated with hypersplenism, but the infectious complications appears to be uncommon given the reported frequency of hypersplenism. Now, like other conditions where hypersplenism is there and they have patients are more susceptible to infections. In celiac disease, the patients, the adults are less susceptible to infectious complications. Now, but there are certain conditions, findings, which suggest that patient can have overwhelming infections. These are when you have the cavitation of the mesenteric lymph nodes or in the lungs. These are the patients of celiac disease with hypersplenism who have poor prognosis. Now, how do you detect hypersplenism? Of course, the most very important in clinical practice. So whenever you see Howell-Jolly bodies or target cells or acanthocytes, okay, it is suggestive of hypersplenism. But remember, this may not be apparent if there is only a mild form of hypersplenism. So another important way to detect hypersplenism is to count the pitted erythrocytes. These are something that resemble like the golf ball. And this, of course, is detected by the interference contrast microscopy. This technique, of course, is not available so therefore, and it's quite expensive. So usually in clinical practice, we look for the Howell-Jolly bodies and the acanthocytes. But recently, a new study has come in this year in February 2025, which uses the flow cytometry to detect the amount of red blood cell high mannose glycans, which are normally removed by the sleeve. And this is a good measure of splenic function with a sensitivity of 93% and 100% specificity. Of course, it needs to be tested in a larger scale before it can be recommended as a test for diagnosis of hypersplenism. No, it is not that all patients of celiac disease should be investigated for hypersplenism. And some of the patients who have at a higher risk of hypersplenism are the patients who have refractory celiac disease or who have enteropathy-related lymphomas or have concomitant autoimmune disorders, patients who are diagnosed at old age or have previous history of major infections or sepsis or thromboembolisms, or patient has splenic atrophy or mesenteric lymph node cavitations. So these are the patients of celiac disease where there is a high probability of documenting hypersplenism. So to sum up my talk, celiac disease, please, next slide, please. Yes, please do not move now. So to sum up, celiac disease is a multi-system, multifaceted disorder. It is not just restricted to GI. There's a misconception among clinicians and students that celiac disease is related to the small intestine. In fact, in adults, the extra-intestinal presentation of celiac is more commonly seen rather than the intestinal complications. It can present at any age. It can present in all phenotypic expressions like classical or non-classical or silent or even potential celiac disease. One should have a high suspicion, especially when you have refractory anemia, you have unusual complications like osteoporosis in a young person, recurrent infections, autoimmune diseases, unexplained infertility, and so on. Diagnosis is not only based on serology, there's a documentation on histopathology. And of course, these tests are always done when the patient is taking gluten-rich diet. And the lifelong gluten-free diet is the only proven therapy, and it eliminates most of the symptoms, though some of the symptoms, of course, do not respond as efficiently as compared to other symptoms. Now, the early diagnosis of celiac disease is very important to prevent the complications and improve the quality of life. Remember, think beyond the gut. Celiac disease wears many masks, which I have already demonstrated in the 7 cases, which I have discussed in short. Thank you very much.
Thank you, Professor Sudhir. Now, yeah, Sudipto.
Yeah, it was an excellent
it-
lecture, deliberation, Professor Mehta. You have shown at least 7 phases of celiac disease, which is really very nice. I was just going to ask you a question. What about the refractory celiac disease?
Yes,
Well,
refractory disease are those patients actually where the compliance is also poor. These patients are some of these patients, they continue to have some gluten off and on in the diet. And that is the commonest cause of refractory celiac, what we see in clinical practice. Of course, and there, of course, the patients who are associated autoimmune gastritis or H. pylori infections, or they have giardiasis. No, these are the patients probably you do not identify these conditions, and they are usually labeled as refractory celiac disease.
yeah, and another thing to remember that if you have a patient of refractory celiac disease, always think about EATL, that is enteropathy associated T-cell lymphoma. Yeah, or are we missing the diagnosis, or like whether we are missing the tropical sprue, or that is because there are a host of questions from Dr. Shibendu Ghosh regarding this celiac disease in the chat box. Yeah, the first questions was, can we diagnose celiac disease without a biopsy?
Yes, I've told you, like, for example, in a patient who has dermatitis herpetiformis, and only this, if the serology is positive and that the dermal lesion, skin lesion is confirmed histologically, you do not have to go for the duodenal biopsy.
Yeah, that is for dermatitis herpetiformis. But his question was, can we diagnose celiac disease only on the basis of clinical improvement on gluten-free diet? I think this is not possible.
This is no, because the standard protocol is that once you have a positive serology, you have to confirm on duodenal biopsy. The important is even if the endoscopic appearance of the duodenum appears to be normal, but still, if you have a high suspicion of celiac disease, one should go for biopsies for histopathology.
True, very true. The next question is from Dr. Shibendu Ghosh. Can the histology of celiac disease involve only lymphatic cell? Just 1 minute. It is. It is from the chat box here. I'm just getting the chat box. Yeah. No question and answer. Yeah. Can the histology of celiac disease involve only lymphatic cell infiltrate without any villus atrophy?
No, villus atrophy, because we have the Marsh classification, which is the most commonly. So Marsh, the villus atrophy, because then it depends what is it is the 1 or 2 or the 3rd grade of Marsh, of course, because 1 and 2 can be non-specific.
But the Marsh one, you can have only intraepithelial lymphocyte
infiltration of the
increased number more than 40, but they might not have villus atrophy.
Yes, but then of course there should be a strong clinical suspicion on the basis of presentation.
Yes. Very true.
Yes.
The next question was, can it happen that only iron deficiency is the presentation? I think it is yes.
Yes, yeah, I told you it is the common, even up to 60% of patients.
I think this is a very interesting question which he has put. IgA deficiency and clinical difference with sprue.
What IgA deficiency?
Because, I think there is always a diagnostic dilemma if they are IgA deficient.
Yes. Okay. Yeah. See, in celiac disease, nearly 7% of celiac patients can have associated IgA deficiency. Where if you want to have the serology, either you go for TTGA IgG, or you go for endomyocin, or you go for the anti-DGP IgM.
Yes.
IgG. Yes. They are more specific. Almost that is anti-GP, anti-GP IgG is almost 100% specific for diagnosis of for celiac disease in the presence of IgA deficiency disorder.
Yeah, yeah. The other question, I think you have discussed lymphoma and celiac disease. You have discussed, and also Howell-Jolly bodies and alpha thalassemia versus hyposplenism. You have discussed, I think. Regarding, he has asked the questions of H. pylori and celiac disease.
Yes, H. pylori, in fact, it is one of the differential diagnoses when the patient presents with GI symptoms of celiac disease, and GI disease again is more common.
Okay. There is a clinical scenario. This is Dr. Kalpana, neurologist. We have a 50-year-old male with more of cerebral ataxia and less of abdominal symptoms since 1 year. Biopsy and 1 year back was normal. Repeat biopsy now results awaited. Antigliadin and TTG endomysial antibody all needed to diagnose. Since in the government setup, investigations are constrained due to financial issues.
So now
Any comments?
yes, for ataxia, just make sure that celiac disease comes into play when you are considering a non-hereditary cerebral ataxia. And if you find that there is no other cause of, one should look for, and this patient TTG was negative. What about the IgA level in this patient? Was IgA level was done?
I do not know, but it is not mentioned, I believe.
So biopsy was done. Biopsy was normal.
Yeah, the first biopsy 1 year back was normal. The repeat biopsy they have done, which is results are awaited. The antigliadin, TTG, endomysial antibody all are needed. But I think they have not done it because of the financial constraints. It is very difficult.
I'll comment on this. In fact, at times what happens, there's a patchy involvement of the mucosa.
Yeah.
So in the first biopsy there, probably the biopsy must have been taken from the normal mucosa and you have missed it. Okay.
Yeah.
And that's very important. So then the patient should be, of course, continue to be given gluten, challenge should be done. And you repeat biopsy after 6 to 8 weeks.
Yeah.
And then probably you can pick up these patients on biopsy. And anti-gliadin antibodies are actually not really advised in the standard protocol. Protocol. Yeah. Because they really they can, because they are false positive in nearly 20% of normal individuals also.
And another thing is regarding the biopsy also. I think the protocol is we need to take 2 biopsy from the duodenal bulb and also 4 biopsy from the distal duodenum. And I think unless you take adequate number of biopsy, you might have missed the histology changes anyway.
And it's very important that the duodenal bulb biopsy should be put in a separate vial.
Yeah.
And yes, we do not mix them because there could be a confusion because the mucosal architecture is slightly different between the 2 sites.
Yes, very true, very true.
Yes.
I think that's a single antibody which is mandatory to be done. I think everybody knows anti-TTG in most of the cases. Professor Jayanta Chakraborty says what is the cause of basal ganglia, cerebral calcification, and celiac disease? Anything?
No, it can be real. Of course, celiac disease is associated with neuropathy. And this one peripheral neuropathy does not respond so well to gluten-free diet as compared to other manifestations of celiac disease. So neuropathy, one should always, besides non-hereditary cerebral ataxia, neuropathy is very also important manifestation of celiac disease.
Yeah, yeah. There is a chat box regarding in some the normal finding of duodenal biopsy may have absent villus appearance in proximal part. Didn't get that, sir. Request to kindly explain.
What? Can you repeat that, please?
I think regarding in some biopsy, I think you have mentioned that duodenal biopsy can be normal, may have absent villus appearance in the proximal part.
Yes.
I think, didn't get that. But he could not understand what did you mean by that.
No, it was at the duodenal bulb where you can have mild degree of atrophy is there.
The duodenal bulb biopsy should be kept in a separate vial so that there is no confusion. There is regarding the architectural,
There could be a mild villus atrophy in the duodenal bulb.
Yeah.
That can be confused with the diagnosis of celiac disease. But then you have to see the distal biopsy, of course, should also show the villus atrophy.
Yes. Yeah. I think That's all really the questions. And thank you very
Okay.
much.
Okay. Thank you, Sudhir
Thank
and Sudipto. Now, one of our course director, Professor Partho Sarkar, will give the vote of thanks. Partho,
Thank you, Dr.
Thank
Sarkar.
you.
yeah,
Okay.
this was very nice presentation, Sudhir.
Thank you, thank you.
Very nice.
Of course, actually, I had just because many of the participants, students would be from your state only, and where their reported prevalence is low as compared to North Indian area population.
True.
I took up to that we still even in a population where rice is the staple diet, one should have a high index of suspicion for celiac disease. That is very, very important. Otherwise, you miss the diagnosis, and then the patients can have complications like the enteropathy-related T-cell lymphoma or the things, which I've already said in all the case osteoporosis, which remains unexplained.
You have given a very good overview of this case. I always hear you giving hematology lectures on hematology, but today you have given a very good lecture on the really internal medicine. Now, Partho Sarkar, will you conclude?
Okay, sir. Thank you, Dr. Mehta,
Thank you,
for this
Dr. Sarkar.
excellent overview and insight on the subject. It is a kaleidoscopic view of different type of presentations. So it is nice to hear you. And I think the postgraduates will be hugely benefited with this talk. And also my sincere thanks to the chairperson, Dr. Sudipto Ghosh, for his nice moderation and also a good interaction with the audience regarding so many questions. Those are very critical. And Dr. Mehta has answered all those things. So it is altogether a very good experience to have a discussion on this topic. My sincere thanks to also the coordinator of this program, Dr. M.K. Rai, Dr. Pathak, Dr. Dipanjan, our secretary, Dr. Partho Karmukar, who actually contacted Dr. Mehta, and then none than the Dr. R.N. Sarkar, and the audiences also have enjoyed the session, I think. So now over to Chairperson Dr. R.N. Sarkar, and it will, I think R.N. Sarkar will conclude it with the next program.
Before
Thank you.
concluding, I am thankful to all the faculty members as well as students who have attended this class, and they are definitely benefited, as said by Professor Partho Sarkar. So I'm really thankful to all of you. So
And
Dr.
our next class,
Mehta and Dr. Ghosh also. Over
Thank
to
you very
Dr.
much.
No,
Professor
Partho.
Sarkar sir to conclude.
Partho, you conclude with the timing of the next class. I think 24th, no?
Yeah. So we will let you all know over WhatsApp who will be our speaker and who will be chairperson and what would be the topics.
Okay, we conclude. Thank you
Thank
all.
you, Dr. Sarkar, Dr. Partha, Dr. Ghosh, and everybody, the team. I really enjoyed this platform. And of course, the West Bengal team is always been very dear to me. And over the years, we had a lot of interactions. And before COVID, I think we had taken a lot of classes, PG classes for CBC. So really enjoyed coming to this part of the, it is one of the most area which is very close to my heart, because my Nanial, in mother's side, they resided in Calcutta for almost 70 years. 70, yeah. My Nana, grandfather, maternal grandfather, he came in 1948 to 1949. So I used to visit in my childhood. So Calcutta is always
They are still here in Calcutta?
No, my uncle is there. One uncle is there. I had 7 maternal uncles. No, over the years, some unfortunately have demised and they moved to other places. So still, but the place, still I visit Calcutta whenever I have a chance, especially because of your invitation from the Bengal side, API and this. And I always take this opportunity to visit my relatives there. Thank you.
So you are a good friend of mine for decades together, but this story was unknown to me. Okay.
Yeah.
So very good. And in future also we will contact you if necessary for
I've always enjoyed the
or anything
hospitality
else.
of the Bengal and the sweets of Bengal. Of course, they
Yeah.
Okay. Thank you.
Okay.
Thank you, everybody. May I leave?
Thank you.
Thank you
Okay.
very much.
Thank you.
Okay,
It's
bye.
you
Have a good
in the
day. Have a
down
good
memory
day.
lane.
Yes.
Mm.
Have a good day.
Thank you.
Bye.
Okay.
Leave,